Hmm. Yang lompat malah asas.
8 oke. Eh,
Selamat. Good afternoon. Hello.
Hi, Dr. Maliawan, is it?
Yes, it's me. How are you? Yes, I am. Maliawan. Yeah, Sri Maliawan.
Wait, hold on.
Okay. Thank you. Now here in the evening, just
It's 6 p.m., right? Yeah, in Singapore, it's 7 p.m.
Yeah, 7 p.m. right now in Singapore.
Yeah. So, you're talking first, right?
Okay, yeah, just a brief speak to open this webinar. Okay.
And then the president of the ICS, is it?
Yes, I am.
Yeah. Okay, good.
Yeah. Yeah.
Then the other speaker, is it Dr. Guido is not on, right? He's not coming on.
Not yet. If not, just me to
That's
give
right. That's right.
some
Good.
speak and
Otherwise,
then
very hard
continue
to coordinate.
by
Yeah.
legal. Okay.
All right. And who's the first speaker after you then?
All right.
Is it me?
The first speaker is no. That's the first. We should talk about a legal
The
issue in
legal
medical
one.
ethics. It was
Yes.
speak first, and then after that, maybe you the last speaker.
Okay, because Dr. Kasmadana asked me to speak second. I'm okay, whichever. Let him speak first.
Okay. The moderator Ms. Master of the
Yeah.
ceremony, who moderated.
I guess,
Okay. You can talk.
Dr. Malawan, I just got a text from Pandey.
Yeah.
She said that is Pandey there? Maybe.
Yeah. I mean, Saturday night.
I see. Okay.
Yeah.
So, because of that, she said that Dr. Kusuma Dana wants to do
So
later. But I'm okay either way. If he wants to do
okay.
first, I'm okay.
Let the moderator, who moderates, can start this webinar.
Okay.
Yeah, thank you, Doctor. Good afternoon, ladies and gentlemen. Welcome to the webinar Broad Spectrum in Infertility. My name is Elisha Adnil, and I am honored to be your moderator for today's event. First, let us express our gratitude to all distinguished speakers, participants, and organizers who have made this event possible. Today, we will explore many aspects in fertility, from medical aspects and also legal aspects, which are crucial in advancing our practice in obstetrics and gynecology, particularly in managing infertility. Before we begin, it is my honor to invite Prof. Sri Maliawan, MD, PhD, FICS, as President of ICS Indonesia section, to deliver the opening remarks. Prof. Sri Maliawan, the screen is yours.
It's 19 hours.
Thank you, Mr. Moderator, Ms. Moderator. Thank you. On behalf of the International College of Surgeons Indonesian section, I am very that's a great honor to open this webinar because it is a very important issue right now. The topic is very interesting. So what I first is thank you for the 4 distinguished speakers. However, the first speaker will be this webinar must must contain at least legal aspect or ethic, and then continue by the first speaker, second speaker, and third speaker regarding infertility and so on. I hope this will very interesting issue, and then again I hope later there is a discussion, a lot of discussion and so on. And then thank you again for the distinguished speaker. Thank you. I give back the moderator for this screen. Thank you.
Thank you very much, Prof. Sri Maliawan, for your warm and inspiring words. So now I think we are ready to begin the main session of our webinar. We are honored to have a lineup of distinguished speakers who will share their expertise and latest insights of infertility. We will have a Q&A session after all the topics have been discussed by the speakers. If there is any questions, you can ask the speakers directly during the session or write them in the chat box. To begin, allow me to introduce our first speaker, Dr. Andreas Andre Lonsen, who is thoracic, cardiac, and vascular surgery specialist with expertise in vascular endovascular, Bachelor of Law, Master of Law, and will be presenting on legal issue and medical ethics. Dr. Andreas, the screen is yours.
Yeah, good afternoon. Thank you very much for the international FICS, especially Indonesian FICS. Honor for the Professor Sri Maliawan and Master Suresh Nair. Thank you very much for this afternoon. I would speak in mixed language, Indonesian and English. I would share my presentation. Okay. Okay. Can you hear my voice?
Yes,
Clear?
very clear.
Okay.
Thank you.
Thank you very much. Okay. Before we talk about legal, ethics and legal in medical profession, I will edit, not only ethical, but ethical discipline and legal issue in medical profession. We would hear about we would see about the film in Canada, about medical error in Canada. Sorry. Just only 1 until 2 minutes ago. This is the most important issue, but almost of us.
This is not about shame and blame. This is about changing the game. It's well known cancer is the leading cause of death in Canada. It's well known heart disease is the second leading cause of death in Canada. What's not well known, and in fact is a well-kept secret, is that the third leading cause of death in Canada is medical error. Medical errors.
Oke. Tadi kita sudah mendengarkan tentang isu medical error. Ya, in fact, in Canada ternyata kematian nomor 3 yang tidak diketahui oleh masyarakat di Kanada, ternyata adalah medical error. Itu betul-betul mengejutkan mungkin bagi masyarakat di sana, termasuk in Indonesia. Nanti saya akan cerita tentang bukan hanya di Kanada, di negara lain demikian juga. Nah, sekarang secara garis besar, bahwa in Indonesia, in medical practice, we have 3 big norm. Number 1, the first norm is ethics norm. The secondly is discipline norm. And yang ini yang paling penting the most important in Indonesia, yang isunya sekarang undang-undang kesehatan yang baru, new undang-undang itu adalah law, norm, legal norm. Nah, yang tidak disadari, yang kita kurang realize kurang menyadari, ada beberapa pelanggaran norma etik yang tumpang tindih, ya, overlapping, bisa itu berupa pelanggaran etik, itu juga bisa berupa pelanggaran disiplin, juga pelanggaran hukum. Oke, sekarang kita masuk ke etik, ya. Kalau kita bicara tentang etik, ya, dari empat, ya, pilar, ya, 4 pilar besar, yaitu yang pertama otonomi. Ini hanya mengulang saja ya teman-teman, ya. Sorry. Yang pertama otonomi, bahwa setiap pasien mempunyai hak menentukan nasibnya sendiri untuk menerima pengobatan, perawatan, apapun yang dikenakan kepada dia, termasuk menolaknya. Kalau kita bicara yang kedua, pillar number 2, the secondly pillar itu adalah beneficence. Ya, setiap dokter, tenaga medis harus memberikan manfaat pada saat dia akan melakukan suatu tindakan. Ya, bukan malah merugikan, tapi memberikan manfaat. Saya sering bicara kepada residen-residen, mahasiswa saya, calon dokter bedah TKV di Indonesian University, ya, medical faculty, saya bilang, pada saat kamu melakukan apapun, pikirkan beneficent, manfaat. Bagaimana caranya? Kita harus mempertimbangkan manfaat dengan risikonya. Benefit and risk. Ya, if the benefit is more dangerous, ya, than the beneficent, ya, maka harus berhentikan, stop, jangan dilakukan. Ya, kita masuk kepada non-maleficent. Non-maleficent kalau bahasa Inggrisnya adalah, penekanannya adalah first, do no harm. Harm itu membahayakan. Oke. Nah, dalam bahasa Latinnya primum non nocere. Ya. Jadi kalau kita tahu tindakan kita itu membahayakan pasien, just don't do it. Jangan lakukan. Tidak boleh dilakukan. Nah, bagaimana kita tahu bahaya atau tidak? Ya, saya sudah mengeluarkan buku tentang scoring. Khususnya kalau Prof. Mariawan pasti tahu, ya. Skor untuk pembedahan. Ini kalau anestesi jelas, asas skor. Kalau asal 5 dioperasi pasti mati. Jangan dilakukan. Dan yang berikutnya justice. Kalau kita bicara tentang justice, kita tidak membeda-bedakan ras, suku, agama, politik, dan sebagainya. Oke, kalau kita bicara isu tentang etik, maka yang dituju adalah ini, isu tentang patient safety. Mengapa patient safety ini menjadi tolak ukur, ya, baik di akreditasi atau pembicaraan isu etik? Lah, memang setiap dokter, tenaga medis pasti menghendaki setiap pasien itu selamat, ya, minimal selamat. Apakah lebih baik atau tidak, kita tidak bisa menjamin itu. Karena hubungan dokter dengan pasien adalah in spanning verbintenis, adalah usaha yang maksimal. Jadi terapeutik, hubungan hukum terapeutiknya adalah in spanning verbintenis, bukan menjamin atau memastikan, ya, hasil, tetapi in spanning verbintenis, usaha yang maksimal. Nah, di dalam satu ada badan di Amerika, di Australia yang disebut dengan TPS, Threats to Australian Patient Safety, ada beberapa definisi-definisi yang mereka keluarkan, termasuk yang insiden, ya. Nah, dilaporkan sekitar 70-90%. Ini mereka lakukan penelitian, ya. Nah, insiden ini terkait dengan pengetahuan atau keterampilan praktis, ya, practitioner. Nah, termasuk di dalamnya adalah diagnosis yang tidak terjawab atau tertunda. Nah, ini nanti kita akan fokus di sini. Ini yang tidak sering dibicarakan mengenai diagnosis, harmful diagnosis, ya. Oke, karena WHO sudah membunyikan, mencanangkan, maka saya sampaikan kepada teman-teman di sini. Oke, yang menonjol di dalam definisi itu adalah kejadian tidak diharapkan, adverse event. Nanti teman-teman bisa perhatikan di sini, ada suatu kejadian yang mengakibatkan cedera yang diharapkan pada pasien karena suatu tindakan. Ini yang disebut commission. Harusnya tidak dilakukan, tapi dilakukan. Itu namanya commission. Ya. Sebaliknya, seharusnya dilakukan tetapi tidak dilakukan, ya, itu namanya omission. Commission, istilah ini sudah masuk ke dalam bahasa hukum. Apa itu? Jadi hukum pidana itu ada dua unsur. Unsur kesengajaan, doulos, dan unsur kelalaian, culpa, bahasa Latinnya. Nah, culpa mengandung di dalamnya unsur ini, commission dan commission. Kalau bahasa hukumnya kelalaian, kealpaan. Apakah ada kaitan nanti etik, disiplin, dan hukum? Ada. Bahkan di disiplin, norma disiplin yang akan dikeluarkan baru-baru ini, teman saya, orang majelis disiplin profesi sudah mengatakan, nanti akan keluar ini, dalam bentuk mungkin Permenkes. Apa yang disebut, kalau dulu di KKI ya, Perkonsil itu ada 28 butir mengenai pelanggaran norma pelanggaran disiplin. Nanti di Permenkes ini juga akan ada yang baru. Ya siap-siap aja. Istilah-istilah lain tidak saya bahas. Nah, ya, there are 5 ethical issues in healthcare. Ada kurang lebih 5 yang penting. Ya, the first is 21%. It's about balancing care, quality, and efficiency. Ya, second, 17% allocating limited medication or tool of support. Ya, dan seterusnya. Oke. Nah, there's a new issue ya. Kalau nggak salah munculnya tahun 2024 bahwa WHO Global Patient Safety Challenge ini dicanangkan. Pencanangannya dengan isu yang keras di sini, yaitu medication without harm. Nah, apa yang gerakan yang harus dilakukan, yang akan dilakukan WHO dengan mencanangkan ini? Ini melibatkan hampir semua negara yang hadir, yaitu melakukan yang namanya significantly reduce serious, secara serius menurunkan secara bermakna, ya, avoidable, menghindari harm to medication error, kesalahan-kesalahan medik, dan unsafe medication practices. Oke, ini beberapa ya. Kalau bicara tentang safety risk di in healthcare system, beberapa, tapi tidak kita bahas pada malam hari ini karena waktu saya kan 15 menit. Oke. Nah, yang muncul belakangan ini, isu yang muncul adalah melakukan ini yang disebut mencegah terjadinya preventable diagnostic harm. Nah, itu apa? Jadi ternyata diagnostik yang berbahaya yang sebenarnya bisa dicegah itu dibagi dua, di mana terjadi pada miss opportunity dan no miss opportunity yang berakibat ke mana? Ke harm. Harm apa itu? Yaitu terjadinya delayed or wrong treatment, kesalahan pengobatan atau keterlambatan karena diagnostik yang berbahaya, ya. Di sini padahal ada di lingkaran yang B ini sebenarnya preventable diagnostic harm, ya. Di sini memang ada terjadi missed opportunity in diagnosis due to system and or cognitive factor, ya. Di sini ada delayed or wrong diagnosis but no clear evidence of missed opportunity. Di lingkaran C ini karena delayed wrong diagnosis associated with patient harm but no clear evidence of missed opportunity. Nah, sekarang kita coba lihat definisinya masing-masing. Jadi bagaimana mendefinisikan diagnostic safety event, kejadian diagnostic event. Jadi penelitian dari AHRQ, Agency of Healthcare Research and Quality, ya, disebutkan di sini definition dari kriteria is met if one or both of the following occur, ya, muncul ya kalau satu atau dua, whether or not the patient was harmed, walaupun mungkin pasiennya tidak berbahaya atau dalam kondisi yang berbahaya. Pertama adalah delayed, wrong, or misdiagnosis. There were one or more missed opportunity to pursue. Jadi ada satu atau lebih kesempatan ya untuk mencapai identifikasi yang akurat dan tepat waktu dari diagnosis itu. Ya. Oke, yang kedua, diagnosis not communicated to the patient. Tidak dikomunikasikan kepada pasien. Jadi bisa saja itu akurat diagnosisnya ya, ada, but it was not communicated to the patient. Tidak dikomunikasikan kepada pasien. Ya, mohon maaf ya. Termasuk mungkin familinya, keluarganya, atau yang mewakili ya. Nah, definisi-definisi mengenai diagnostic safety ini adalah yang pertama accuracy. Berarti diagnosisnya is correct. Timeliness, absence atau significant preventable delay. Tidak apa ya? Tidak ada penundaan ya, tepat waktu. Kemudian bicara tentang efisiensi ya, appropriate, tepat ya, use of resources, sumber-sumber untuk menegakkan diagnosis ya, termasuk pemeriksaan-pemeriksaan lebih lanjut dengan teknologi yang tinggi. Kemudian jangan lupa kalau kita bicara tentang about diagnostic safety adalah sifatnya adalah patient center. Jadi patient center artinya ini harus dikomunikasikan, dimengerti oleh pasien. Kemudian equitable ya. Ini penting ya. Absence of preventable unwarranted variation ya in diagnostic process di antara kelompok-kelompok ini secara sosial, ekonomi, demografi dan seterusnya. Nah, bagaimana diagnostic excellence yang harusnya dicapai? Ya usaha ini make correct and timely diagnosis yang tepat, yaitu menggunakan resources yang jangan terlalu banyak ya, sedikit mungkin ya. Kemudian libatkan pasien ya. Pengalaman-pengalaman pasien itu harus tahu. Banyak tuh pasien saya kalau tanya, dulu dioperasi di mana, dokternya siapa, sakitnya apa, hasilnya pemeriksaan PA-nya, tumornya, enggak ada yang tahu. Wah, ini memang pasiennya nggak dilibatkan sama sekali ya di dalamnya ya. Kemudian manage and communicate uncertainty to patient. Ya, di manage ya, dikomunikasikan hal-hal yang tidak pasti, ketidakpastian di dalam terapi itu kepada pasien. Kemudian tolerate, kalau bisa mentoleransi. Kalau penundaan-penundaan, kalau memang treatmentnya may be harmful, membahayakan. Jadi kalau bisa ditunda justru. Ya, saya kasih contoh. Di bedah jantung, ini Dokter Maizul, ini sangat baik contohnya. Waktu itu disiapkan pasiennya sudah mau operasi jantung. Tapi Dokter Maizul mau menegakkan diagnosis kalau pasiennya sudah terjadi hypertension, pulmonary hypertension atau tidak. Nah, dia menggunakan teknik yang namanya tes oksigen test. Ternyata dengan oksigen test, tekanan PaO2-nya ini tidak naik, tidak berespon terhadap pemberian oksigen. Maka operasinya dibatalkan. Ya, itu ya, make correct and timely diagnosis. Jadi kalau ada seorang dokter bedah jantung, operasi tidak bisa keluar dari mesin heart and lung machine, itu artinya itu harmful diagnosis, tidak diketahui sebelumnya. Harusnya sudah terdeteksi. Gitu ya kira-kira pengertiannya diagnostik yang excellent. Jadi sekarang problemnya bukan karena tindakannya yang salah, tapi diagnostiknya yang salah, tidak terdetek, sehingga pasiennya dioperasi. Ini tantangan juga etik, disiplin, dan hukum bagi teman-teman yang berkecimpung di spesialis fertility. Kalau teman-teman tahu itu angka kegagalannya rendah, ya sangat-sangat rendah, gagal. Tapi di sisi lain, berhasil atau gagal, suatu bayi tabung itu tetap membayar. Itu tentang etik, disiplin hukumnya, apakah tetap dijalankan atau tidak itu. Karena sudah jelas, ya clear, itu pasti gagal. Tapi karena, yaitu, kalau orientasi kita shifted to money oriented, there will be many standard will be decreased. Ya, banyak standar-standar akan diturunkan. Jadi kalau pelayanan orientasi kita sudah ke money, uang, banyak standar akan turun. Itu tantangan. Ini cerita ini berasal, kata-kata ini berasal pada saat Boeing 737 mengeluarkan jenis yang baru, tapi tanpa memberitahu negara-negara yang membeli pesawat yang baru itu. Korban yang pertama adalah Indonesia, korban kedua adalah Ethiopia. Ya, itu sangat menarik isunya. Sorry ya teman. Oke, jadi diagnostik akurasi itu dibangun berdasarkan beberapa tahap. In every step there are diagnosis, bangun ya, build a diagnosis dengan chief complaint atau history, anamnesa, muncul differential diagnosis, dan itu akan muncul confidence, ya, itu yang disebut dengan kepercayaan diri, yakin. Ternyata dari 3 or more differential diagnosis dengan pemeriksaan fisik mungkin berkurang, ya, dengan muncul lagi confidence baru. Kemudian dengan pemeriksaan yang sangat basic dan dasar, misalnya foto ronsen, muncul lagi sampai kepada pemeriksaan lebih lanjut. Hanya muncul satu diagnosis and confidence. Nah, ini yang perlu diperhatikan oleh teman-teman ya, physician dan lain-lain. Kalau terjadi akurasi diagnostik dan confidence-nya not align, ya, tidak segaris, tidak sebanding, itu yang disebut terjadilah miscalibration. Pengukurannya salah, ya, antara keyakinan dengan diagnostik akurasinya itu tidak sebanding. Nah, dokter mungkin tidak mencari pertolongan, baik dari manusia lainnya, dokter-dokter spesialis lainnya atau subnya, atau decision support systems yang lainnya. Pada saat they most needed, terjadilah miscalibration. Nah, ini yang unik ya teman-teman yang perlu disadari. Ini dari penelitian dari Mayer, sudah cukup lama ya, dari 2013. Jadi pada kasus-kasus yang easier case, ya, there is a alignment ya, gapnya not too gapnya itu narrow ya, sempit. Jadi antara akurasi and confidence-nya itu hampir sama. Tapi pada kasus-kasus yang difficult, ini yang perlu dihati-hati. Jadi antara akurasinya yang sudah turun, tetapi confidence-nya justru naik. Nah, ini yang menyebabkan terjadinya tadi itu, harmful diagnosis. Oleh sebab itu, teman-teman harus disupport. Bagaimana caranya? Bangunlah kerangka kerja seperti ini. Supaya sistem di mana teman-teman itu bekerja, di dalam sistem ini, nanti saya tidak usah bahas ya, secara detailnya. Nanti berulang-ulang nanti menghasilkan safer diagnosis yang akan membuat improve value of healthcare, yang satunya the other hand in improve and patient outcomes. Ya, seperti itu ya, kira-kira ya. Nah, ini gap-gap yang terjadi pada negara-negara yang di mana itu, negara-negara yang low and middle income, yaitu comprehensive appreciation of diagnostic safety, ya, kurang. Ya. Kemudian data dari certain care settingnya juga kurang. Kita bermasalah dengan big data kita ya, nggak bisa dinilai sebabnya data-datanya. Kemudian kekurangan ini, culture and psychological safety issue, ini kurang dikemukakan. Ya. Kalau kita hanya meningkatkan teknologi, tapi culture and psychological safety issue-nya tidak ditingkatkan, ya tetap aja banyak pasien-pasien yang akan mengalami misdiagnosis dan akhirnya menjadi harmful untuk suatu tindakannya. Nah, data sources juga data-data dari pasien, clinician sources. Kemudian bagaimana mengukur improvement dan learning-nya. Nah, disarankan rekomendasi dari WHO ini adalah buat teamwork yang efektif dalam diagnostik proses ini. Kemudian tingkatkan dengan di tempat-tempat yang profesional itu about education and training. Harus dibuat pelatihan-pelatihan. Kemudian health information technologies. Kemudian juga approaches to identify, learn from, and reduce diagnostic error, near misses in clinical practice. Harus dibangun work system and culture. And then dedicated funding for research. Oke. Ini saya lewati saja karena waktu ya. Jadi usahakan seperti begini ya, preventable mengurangi preventable harm from diagnostic error. First is diagnostic error, a complex problem. Memang ya, diagnostic error is a complex problem, but promising recent progress. Tapi usahakan ada perbaikan dong yang bermakna. And then strategies ya for clinician to learn and improve and engage the patient. Libatkan ya pasien-pasiennya. Harus. Kemudian safer, buat checklist ya, measure diagnostic actionable step dalam hal improve safety. Nah, ini data lain, ternyata di US disebutkan juga medical error itu sekarang nomor 3. Jadi bukan hanya di Kanada, di US, di Amerika Serikat. Nah, kita lihat malpractice allegation-nya. Tuntutan malpractice-nya di Amerika itu diagnosisnya itu 33%. Tadi kita sudah bicara ya tentang harmful diagnosis. Selanjutnya surgery dan seterusnya. Obstetrik masuk di juga 10%. Dan di tulisan lain di British Medical Journal, memang medical error is the third leading cause of death in the US. Oke. Dikatakan 2,050 100 people in the US die every year from medical error. Ini dari penelitian John Hopkins Study, Modern Medicine, February 2018. Nah, 35% it caused by process of care. Tapi ini in primary care ya, kayak puskesmas gitu ya. Oke. What about in Indonesia? Nah, kalau di Indonesia,
Sorry for the interruption, Doctor, but I think I'm afraid we are nearing the end of the allocated time.
sorry. It just left only sedikit ya. A little ini ya, PPT ya. Sorry ya. Nah, di Indonesia ini 8 kasus saja yang masuk penjara ya. 3 yang masuk penjara. Lanjut ya. Nah, teman-teman nanti ini bisa disebarkan. Ini kalau ada tuntutan pidana. Apapun nanti tuntutannya, gugatannya di bidang hukum, semua harus melalui majelis. Tidak bisa langsung ke pengadilan. Kalau ada masuk di pengadilan itu salah, ya. Itu jelas salah karena ketidaktahuan undang-undang yang baru. Ini dari Bareskrim ini ya, slide-nya ini. Demikian di MDP nanti mengadili disiplin sekaligus dia melakukan. Semua harus melalui majelis. Ya, tidak bisa langsung pengadilan. Nah, rekomendasinya berupa apa? Dapat dilakukan penyidikan atau tidak dapat dilakukan penyidikan. Nah, dasarnya apa? MDP, standar profesi, standar pelayanan, standar prosedur operasional. Oke, ini pasalnya. Lanjutnya, perdata demikian juga. Ya, kuasa hukumnya tidak bisa langsung bawa ke pengadilan perdata. Tidak bisa, harus melalui MDP. Standarnya sama. Tapi jangan khawatir ya teman-teman, undang-undang yang baru ini sifatnya restoratif justice di pasal 306. Kemudian dia juga punya jiwa, maaf. Jadi dia menyarankan untuk penyelesaian setiap sengketa, ya, medical dispute itu harus diselesaikan di luar pengadilan, non-litigation, ya, solution. Demikian yang bisa saya sampaikan. Sorry, I speak in mixed language. Thank you very much. Yeah.
Thank you very much, Dr. Andres, for that comprehensive presentation. We truly appreciate your valuable insights. And now it is my pleasure to introduce our esteemed speaker, Dr. Suresner, obstetrics and gynecology specialist, who will present on infertility and reproductive technology in 15 minutes. Dr. Suresh, the screen is yours.
Thank you very much. I just want to thank Professor Sri Maliawan for this tremendous opportunity to be part of your august program. And I want to give credit to all of you and also all of our listeners to spend the Saturday night when you should be partying actually to listen to our podcast and webinar. Thank you for attending this. I also want to thank Professor Kusmadana, my good friend and colleague, who is the medical director of the Monash IVF Center in Bali, a tremendous clinician. I learned a lot from you, Professor Kusmadana. And I hope this presentation will be to your liking as well. My first slide is a generic one. Mainly, my topic of today's discussion is how do we tailor-make our stimulation protocols in order to provide good optimal care for our patients in order for them to have a live birth and a healthy baby. So that is our definite marker as to how successful we are in our treatment. And this is varied by the ovarian reserve. I'm going to talk to you about a lot about that. Age, I'm going to talk to you about that as well. Body mass index, endocrine parameters, and the previous ART responses, and even molecular markers. Now, we have to balance between being overzealous and ending up with overstimulation. For those of us who are not gynecologists, that's a dangerous condition that can cause thrombosis and heart failure, strokes, and all, and that's not a good thing.
Dr. Suresh,
On the other hand, yes?
sorry, doctor, I think your presentation doesn't get on the screen.
Oh, okay. Let me just get that.
You must change to a slideshow. Not yet.
Yeah, hold on. Let me do that. You're not seeing my slides, is it?
Yes, we can see your slide now. Thank you, doctor.
Can we see the slides?
Yes, we can see. Thank you, doctor.
Okay, so I've just changed the slide, the key concepts. So in order to really have a rationale for individualization, as I mentioned earlier, these are the parameters we have to look at: age, ovarian reserve, and health conditions as well. How do we personalize it? Give me a minute. Yeah. So two things as a take home that we need to remember. There are only two ways to check on our ovaries. And I'm only concentrating on the female of the couple. Always remember that if you want to optimize in the ovarian stimulation, the sperm factors are very critical. And how aggressively you stimulate will depend on the sperm parameters. But that's a discussion for another day. Two things we have to assess: AMH, anti-Müllerian hormone. For those of us who are not knowledgeable about that, it is a blood test, easy to do, rather inexpensive. And an AFC, which is called an antral follicle count, which means the ultrasound of the ovary, and we look at little follicles inside, as you can see in the picture here. In women who have too many follicles, it's called polycystic ovaries, we have to be very cautious. However, there are women who have very bad ovarian cysts, like endometriotic cysts, endometriosis. Their ovaries don't respond really well. So we have to then use more medication to get the desired effect as well. Even if the AMH may show something different, the fact that you have endometriosis is a depressive factor. And the clinicians who are experienced in this will know how to then increase the doses accordingly. Now, all of this will not be possible if not for a game changer. I have to mention, although it's not directly related to this topic, it is integral in the entire of our IVF program. Vitrification is a game changer. Without vitrification, we are stuck. We have to put back our embryos. We have to cancel cycles if we are overstimulated. Cancel cycle, we are understimulated. We can't freeze eggs. We can't freeze embryos well. We can't keep the embryos sufficiently to put it back. That's why in my early days, more than 40 years ago, when we started IVF as a junior doctor, we have to put 5 or 6 embryos at day 2 and day 3, mostly day 2. Now the game changer is vitrification, and we can grow the embryo to a stronger situation, which is a day 5 blastocyst. So how do we individualize? Is individualization important? Clearly it is. If you look at the raw data from Allegra in 2017, broad spectrum of patients, if you fix the starting dose or individualize the starting dose, you get a significant plus 50% improvement in pregnancy rates. And why is that? When do you apply your brakes? Simulation is like driving an automatic car, accelerator and brakes. If you apply the brakes too soon, you slow down the vehicle too soon. If you apply the brakes too late, you overshoot your target. So flexible individualization from day one. How do we get optimal numbers of eggs? Because at the end of the day, your whole success depends on good quality and number of eggs. We can't escape that. So in your, again, the AMH story, you know it declines. And in Singapore, we only began allowing egg freezing in young women only 2 years ago. And in Indonesia, you had been doing this for more than a decade. I laud the government and the fraternity for this, because that's the best way to overcome age-related and condition-related fertility decline. Now, what we want to aim is the purple, not the blue. If you overstimulate, you get into the iatrogenic OHSS, which is caused by us. And if you understimulate, you get iatrogenic poor response, which is also caused by the doctor if he does not or she does not realize the features that are required for us to adjust the dose to get optimal effects. Now, what is AMH again? Where does it come from? It comes from the small and large antral follicles. So largely the small antral follicles. You typically measure that when you're in the menstrual cycle, in the early days of your menstrual cycle. But I'll also show you that we measure the antral follicles when we are stimulating, when we do dual or double stimulation. And I'll talk to you about that in a short while. So is AMH better or AFC better? You can see the correlation between AMH and how much eggs were retrieved. AMH is superior to AFC. And as AMH as a predictor of ovarian response these days, it has been shown to improve clinical outcomes, reduce the incidence of complications without allowing us to go overboard on this, and it reduces the financial burden so that we don't use too much drugs, or we use the appropriate number of amount of drugs without undue cancellation rates. Again, another representation, and I'm emphasizing this because everything hinges on our understanding of how much to give when and how much to hold back as well. And this is dependent on our AMH. Does AMH change from cycle to cycle just like our FSH does? It doesn't. It's a fairly stable sort of molecule. But you can see a downward trend over time. That's why I measure my AMH regularly for my patients undergoing treatment, because if I see a dwindling level and I'm doing IUI in this patient, I will then pull back, take stock, and tell them you've got to embark on an IVF cycle because you have a rapidly deteriorating AMH. And this happens, and we never know why. We don't know how close we are to the cliff. As we go along, the only way to find out is by doing this test, which is thankfully a simple blood test. This is a dosigram where you have age, AFC, and FSH starting dose, and also the FSH levels. And this way we can actually use the AFC and the AMH to tell us. There's another algorithm, I'm not showing it to you here, using AMH, which is superior to the AFC. Same authors as well. In this diagram, you see the AMH showing superiority over the AFC in trying to predict what kind of response you would have in a standard dose of gonadotrophins. What are the pre-stimulation strategies? Besides taking a good sound history of what happened before, whether she has polycystic ovaries, whether her cycles are irregular, whether we have done previous ultrasounds to show what the ovaries look like, what's the antral follicle count, and to decide on how much medication to give her, what is really important as well is her past performance. So stimulation strategies encompass a few other things. How do we start the program? Nowadays, we can do a random start. We can actually start IVF anytime. So especially when you have patients in your country traveling around, your country is a very large country. When someone from Yogyakarta wants to come to Jakarta, and they can only find time at a certain point in their career to come across, you can actually orchestrate it by using contraceptive pills, or you can use estrogens as priming from day 21 to day 28, or you could use a random start where you just begin your stimulation in mid-cycle. It's called a luteal phase start. and start the GNRH analogs antagonist, which is the brakes, in mid-cycle, and yet you can still get a good response, and yet you can do your IVF as well. Now, what about if I overstimulate? These days, thankfully, we have something called the agonist trigger, a trigger that is traditionally used to ripen our eggs is the HCG. But the problem with HCG is it goes up and hangs around. It's like, I explained to my patients, it's like a Ferrari engine. You run the engine, but when you turn off the engine, the high octane petrol still goes on and you overheat. Whereas in the agonist trigger, you have the LH coming out to ripen your egg so that you can take it out 36 hours later, but it just goes away. And there are two advantages to that. One, you don't overstimulate because the engine stops and it cools down. And also, it does not damage all your little follicles. Remember, I said that I can measure little follicles, which are called anthrofollicles, after I've taken out the eggs. This is the principle of dual stimulation. I'll talk to you about that in a short while. And this has opened the doors of improved IVF care tremendously in the last decade or so. We have two main ways of stimulation, antagonists and also agonists. But antagonists are good because you can avoid OHSS. Now, I just want to quickly run through some of the newest medications. This is folitropin delta. There's alpha, beta, and delta. This is the one made in human cells. And it is touted to be good because of the algorithms or nomograms that they have based on the body weight. You see, when we are very heavy, we may need more drugs. When we are lighter, we may need a small amount of drugs. But it's also tied up with the AMH. And we have what is known as the individualized dosing algorithms. And these are the charts that we use. And this is the way we compare between, in micrograms, the delta version and the alpha, which is the traditional gonal F and pyrugon that we use. So it is both comparable. I'm not saying one is extremely better than the other, but we are, again, I want to emphasize moving towards using AMH to see to it how much drug can we use. And these are studies that have proven that. I want to go quickly because I can make my slides available for you in the interest of time. Let me just quickly run through. Now, what happens if the AMH is low? The algorithm will work out a higher dose. And you can see from the algorithm, they have actually done studies to show how much more you need to use without then wastage of gonadotrophins. Now, how about trying to get the best number of eggs? Does it make a difference? Yes, it does make a difference in terms of embryo quality. It does make a difference in terms of whether it's chromosomally normal, and of course, eventually live birth rate and cumulative primary rate. So this study shows that there's a positive association between number of good quality embryos and number of eggs we get by IVF or ICSI. Also, the eggs that we get versus the number of top quality cleavage day 3 embryos, it also holds true even at the earlier stage of embryo development. Now, there has been a previous study that shows the older studies that showed that, there's an association that if you have higher and higher egg numbers, your pregnancy rates becomes static and drops as the time goes on. And that is actually a spurious effect. It is because more of the cycles have been changed from fresh. These are all fresh cycles into frozen because they want to avoid OHSS. So it's not a genuine effect. So if you look at the newer studies, where there are 400,000 definite stimulation, you'll find that the decline in the pregnancy rate is because of the conversion to a frozen cycle. And therefore, you will notice as you get more eggs, you get a higher cumulative pregnancy rate because you are now converting from fresh to frozen, and you're still maintaining the efficiency of the production of eggs and embryos and pregnancy rates. You see, so the difference is clear. I will just quickly run through in the interest of time. Okay, so there's been always a criticism in the old studies that if you get a lot of eggs, you don't get chromosomally normal embryos, it damages the eggs. Recent studies have shown that this is not true. So the emphasis of, as we teach our IVF doctors, is make more eggs without running the risk of OHSS, and therefore you will get more embryos to do PGTA, which is actually allowed in Indonesia, it's not allowed in Singapore. And therefore, when you get more eggs and more embryos, you get more chromosomally normal embryos, and your pregnancy rate shoots up to 60% and above. And this is another way of showing that if you look at the number of M2 oocytes, the more you have, the higher, and the younger you are, the higher, the faster to pregnancy you get to pregnancy, and the higher your pregnancy rates. What about the poor response? There's something called the Poseidon sort of grouping. You might take a picture of this. Based on this, we know that ovarian response is two factors. One is age and one is number of oocytes. Sometimes you have young women with low oocytes, but chromosomally normal. So it's better to have a girl who is 30 years old with maybe 6 or 7 eggs, because at least a few will be euploid, rather than a 40-year-old with 10 eggs. So age is very, very critical and important. So how do we do this? Now, in the individualization of stimulation, you must always remember that there are some women who have genetic disorders that whatever you do, you can't get the eggs to, or rather ovary to respond to the stimulation. And these are the genetic abnormalities. And in recent times, I'm not going to go too much into it because this is not something we have the skills to do, is IVM. Kappa IVM, the Vietnamese are very good at this. Dr. Tung and Dr. Lan are world leaders in taking out the eggs without stimulation, no drugs. And then that's also an individualization of the condition. And they have reports of those who are FSH resistant, and they do non-stimulation, no stimulation, in vitro maturization using the kappa media, which was first invented by the Brussels team, and they're going to commercialize it soon. I know of some IVF centers in Indonesia that are also planning to start on this. Now, what about, I'll just quickly run through this one. This is in the interest of time. Now, what about how do we then improve our success rate at growing eggs by using what's known as ancillary treatments? There are two main molecules that I use. One is HCG. It is present in highly purified HMG. The medication is called Menopur, and this MERIT study has shown that the pregnancy rates are better. And you can see the LH remains the same, but it's the HCG that rises that gives you a better pregnancy rate. And now they've come with the pen, which is easier to use. This is a company that has the oldest drug and the most new drug. But what about LH? The two companies that have these medications are in constant discussion. One is at liberty to use one or the other. LH is the pure LH, similar to the molecule that the body produces. So in those women in whom you have hypoc, it is suggested that it's maybe better to use for hyporesponders LH as a pure molecule compared to the HCG molecule, as you can see here. Now, in poor responders, we generally use LH, but ironically, in the PCOS patients, we also use LH because in PCOS patients, although the basal LH is high, it is actually inactive. And therefore, the bioactivity of the LH that is circulating in the patient is really not as effective. And therefore, you might wonder why we have to use additional LH in patients with polycystic ovaries. It is because of the bioactivity. So let me just quickly run through. This is the case I was talking to you about. Extended LH administration in that dosage, 150 to 187, has been found to have a positive effect of the growth of the follicle because they are born with inactive pituitary glands. They don't have the FSH, they don't have the LH, and they have a good AMH. They in fact overstimulate sometimes. They have an excellent AMH, excellent AFC. they need exogenous FSH and LH. Now, I want to say a few words about dual stimulation. This is a very exciting area. More and more people are interested in dual stimulation. Why is there such a thing as dual stimulation? For the longest time, we never knew that women had produced 2 or 3 waves of follicles. Nature is very wasteful. They grow one egg, and many eggs are actually wasted. I draw the analogy. Imagine that you have a stream of fish swimming by. Nature is only one fishing rod, and we can actually cast a net in IVF and bring, but there are some more fish coming by. So if we were to do our IVF scans, you see the classic theory and waves theory, there are many waves of follicles that are coming, and nature does not use them. So we as IVF practitioners mistakenly thought, okay, we were to rest the ovary for one whole month, but we realized that this is not the case, because we actually can stimulate again, because remember I told you about antro follicles earlier? There are little follicles that are still there, and many a time I actually spend time measuring those follicles, because sometimes the patient have come from somewhere else and they realize, I didn't know I have some more follicles. I said, well, if you look, you shall see. And therefore, we have some small follicles. And after you use something called an agonist trigger, remember, we can never do this if we use the HCG, because it hangs around and spoils my small follicles. We can do this only when we use something called the agonist trigger, where the LH goes up, then disappears, but does not spoil my small follicles. After I've taken out my eggs, I wait for about 4 or 5 days for the luteal cyst and the hemorrhage to settle down, and then I stimulate again. And in actual fact, we have shown that we get better quality eggs, and also better euploid eggs in those countries where you can do PGTA, better quality and better euploid embryos as well. So in 1 month, sometimes you have your patients flying from your entire country to different parts of your country to places where you have good IVF. You can then do dual stimulation, so they don't have to fly back and fly in again. And once they fly back, they have at least gotten 2 rounds of egg pickup. So you look at that red word there, OR and agonist trigger. So why does dual stimulation, why is it so attractive? We can use estrogens to synchronize our follicles. We can then stimulate in the follicular phase, and then we can take out the eggs. And this was first described as a Shanghai protocol by the Chinese, but Ubaldi in Italy expanded it. And now Vatrali has published very widely a lot of data on dual stimulation. And nowadays, the dual stimulation protocol is used in cancer as well. When you have a patient with breast cancer, for example, the oncologist has given you only a short duration of time. You can stimulate, wait for a while, 5 days later, stimulate again, and within a 2-week span, maybe 3-week span, she's all done. She's got many eggs. She can freeze. She's got many embryos. She can freeze, and then she can go through the gonadotoxic treatments that knocks out her ovaries and at least a decent number of eggs and embryos. So how do we do this? I've already described to you. You can prime with the estrogen to synchronize the follicle. In the second phase, you don't need to synchronize the follicle, because your estrogens produced by the previous cycle have already synchronized it for you. And that is why it has been reported that you get a better crop of follicles and embryos growing, you see. Now, some people have also done the other way around. They start in the middle of the cycle, they finish off in the follicular phase, and they start the follicular phase, and they actually can embryo transfer as a fresh transfer. Or you can do PGTA from the first set of embryos, and you're ready to transfer in the second set, you see. So basically, better exploitation of the ovarian reserves and increased chances of euploid embryos. And dual stimulation is also very good for the poor prognosis. I tend to use it for my poor prognosis patients because they only have a few eggs. And every time I stimulate, I take out the eggs, I still see the little ones there. And if we don't stimulate that, it goes to waste. It doesn't come back in the second cycle. And each time we stimulate, we take 1 or 2, 1 or 2, 1 or 2. Cumulatively, you improve, you create a poor prognosis patient into a good prognosis patient. Now, some centers actually keep all the eggs in ICSI one go, or make a blastocyst each time. that is a matter of preference and also a matter of how skillful you are at vitrification of your eggs and your ICSI person. That is something that doesn't necessarily differ from one or the other. So if you look at it, another thing is dropouts. You see, when a person goes through an IVF and then dismayed with the outcome or tired with the outcome, sometimes they don't come back after a month or two, and it takes a lot of effort to come back again. But if it is compact and in a little bit intense, you can stimulate, rest a while, stimulate, and she's done. And you might think that, oh, that's very stressful for the patient. Ironically, actually, they appreciate the fact that they can just get it over and done with in this month, a lull month, so that they can do their business trips and all the other things in the next month. So this is the way the charts go. First attempt, 8% pregnancy rate. After the follicular phase alone is 7% retrieval rate. But if you combine the two, it actually escalates to 15% live birth rate. So good for the poor ovarian reserve, as I mentioned earlier. And then what about if we do back-to-back? Some of my patients ask me, suppose I do a simulation, rest, and then come back the very next month. Actually, your success rates are just as good, but is bi-stimulation better than dual stimulation? No one has been able to prove one way or the other. One is faster, one is slower, 2 months. So they are fairly equal. So the criticism about dual stimulation, maybe if I waited and rested my ovary, I'll get a better outcome. Actually, the ovaries, the human ovaries are very resilient. They don't need to rest. So very quickly, I'll just go on. These are now, sometimes we have come to realize that in the second phase of the dual stimulation, we suppress the pituitary gland quite a bit. And therefore, we find that putting LH, adding LH, about 150 units a day, or HCG, whichever you prefer, actually improves outcome. So this is a schematic to show that data has shown that we get better success rates when we do dual stimulation, when we add the LH, like the yin and the yang, you see? So it's like the engine oil of the engine. When the petrol is put in, this is the engine oil. And therefore, this is the SWOT analysis has been shown to improve outcomes. The only problem is you have increased cost because you need to use the LH. What about patients who are very obese and without PCOS? That's a different group. With and without exogenous outside added LH, we found that we get better embryo quality in those who got recombinant LH in the form of Luvaris or in some of the other medications like Pogovaris and all. So there's also an increased ongoing rate. And we have come to realize in IVF that LH is an integral part of normal stimulation. And these days, I tend to use it almost regularly in nearly all of my patients, except the very young, where they can just get away with FSH because they have a good basal level of LH as well. And you will notice, if you compare the overweight and obese patients, when you use the LH and HMG, the LH patients do much better and have a higher pregnancy rates. But this is an ongoing controversy between the two companies, but it is the jury is still out, I feel. And as a clinician, you can choose whichever you're comfortable with. Now, what about the threshold as to whether it is good response, a better response, and how do I use my AMH levels to decide whether or not I can use the cutoffs that I need to stimulate my ovaries? The values for specific threshold that can predict unexpected poor and suboptimal response. This is a good study. You might want to take a picture of this. It's too little time for me to go through in detail, but remember the thresholds, 20.5 if all cases are included. It is 15.5 picomoles or AFC less than 9. You get unexpected poor response. And if it is AMH of 21.2 and lower AFC of 12 or less for suboptimal responders. So when you see this type of AMHs and all, you have to be aware of as to whether or not they can respond differently using the Poseidon criteria. Just now I showed you the picture of some women are young, got good eggs, but they're just resistant to the FSH, and they're not producing the FSH they need to do so. The same with the hyper responders. If you go beyond the threshold of 35.3 or 18 AFCs, you are likely to, in a young patient, you are likely to have OHSS. If you go 30.9, a little bit lower, and less AFCs for 15, because they're older, these are your thresholds. So these are good guidelines we use as to whether to tweak our doses up or down. So now very quickly, I know I'm running out of time. So added treatments in stimulation, growth hormone and DHEA, these are ancillary treatments we use for poor responders. And we then do mild stimulation for those who are polycystic and overstimulated. And therefore doing small frequent cycles may be as good as doing a big whopping cycle, because always remember, even though you can use agonist trigger to avoid OHSS, the problems related to overstimulation like bleeding, twisting of the ovaries, don't forget, twisting of the ovaries, the torsion, is a omnipresent and extremely dangerous complication. So we have to be very careful. The concept of all and done, whilst is very attractive, we have to be very wary that in the overstimulated patient, there are other ancillary major problems that can occur, torsion, bleeding, and that can really be a catastrophic thing. So I always caution my IVF practitioners, be vigilant. It's good to be all and done, but it's also all right to do one cycle and a dual stimulation, two gentle ones rather than a whopping heavy one. So I just want to go through a quick few words about PPOS. This has become very popular. We don't need to use the antagonist. We use progesterone from the beginning of the cycle to stop the pituitary gland from releasing LH so that we don't release our eggs. And this is really exciting. Again, this was derived from the Chinese who did multi-center trials. And without using antagonists, we use PPOS as the short form. Progesterone actually goes at the hypothalamus level, at the GnRH level, and prevents the pituitary gland from releasing LH. And that is a tablet and or injectables, but usually tablets. I tend to use dufaston or dihydrogeston, which is easy, inexpensive, and good to use. And so I also have done dual stimulation, PPOS in one cycle and antagonists in other cycles, and I found the results pretty reproducible, pretty good. So again, very quickly, these are all, just to tell you, these are all the progestins you can use. I'll make all of this available for all of you. You can use any one of this. I just use dihydrogeston, and you can use any one of this. It doesn't really matter. Some people say that if you use MPA, too much of a profound suppression. So if you're worried about that, you can use dufaston, you can use utrogestan, and that'll be just as good as well. And these are all orally used. So the patient has one less injection to use. Now, do you do it flexible like we do in the antagonist? Doesn't really matter. If you want to save, the cost, or maybe starting the tablets earlier, you could do it. But especially if you think that the other uterine pathology during monitoring, but it is not necessary. In my opinion, you might as well start from the beginning and then not worry about it. Now, I've always been asked, can Visane actually be one of the PPOS medication? The answer is yes. We have had a lot of endometriosis patients, even with big cysts. Always remember, do not take out the cysts of young women when they have big ovaries. Do ovarian stimulation and preservation first. Because even the best of surgeons, if you do a cystectomy for endometriotic cysts, you can actually crash the image. You can even render the whole ovary incompetent. So always remember, work with those of us who are laparoscopic surgeons, work with your IVF buddies, try to get some eggs at least and some embryos, better than none, and then use Visane for a while. You can use that as a PPOS methodology and take your eggs, make your embryos, preserve it, and then do your surgery. whether you want to do it as a primary surgery or in a two-stage procedure like Donna mentioned, drain the endometriotic cyst, give GnRH analogs for 4 months and go back and ablate so that you preserve as much ovarian function as you possibly can. This is a big movement that is going on in Singapore. We have a major issue. There are a few suits going on in court right now involving doctors who have taken out the endometriotic cyst without due counseling. So please beware, work with a IVF buddy, be very careful, especially when you have bilateral endometriotic cyst. That is really critical. This patient, which we are talking about, which is suing the doctor, unfortunately, had been rendered menopausal at the age of 36 when she had 2 endometriotic cysts that were taken out. So this is real. This is real. This is real enough for us to team up and make sure that we have an opportunity to preserve our fertility. So what are the KPIs for stimulation? These are my last 4 slides. These are the KPIs that we are currently using, key performance indicators. The ovarian sensitivity index means how much medication you use and how many eggs you got at the end of the day. There's something called FOD, where we have how much of the follicles you had at the time you're going to trigger, and how much, and based on how much of the starting point, how many follicles you had, and how many you managed to grow, because not all the follicles are going to grow to your pre-follicle states. And then ORR means at maturation, when you trigger, we hope that we can get at least 80 to 95% of the eggs. And one of the ways in which I tend to do it, and I know it is not widespread in use because it's really hard work, I use a double lumen needle, and I flush and flush and flush and try to get every egg I can. Time consuming, a little bit more expensive. The follicle to oocyte ratio is the total number of eggs you can get according to your starting point, AFC. These are the KPIs, but they don't really tell you. These are the diagrammatic representation. I'll go quickly through it so that don't worry, I will make these slides available. So now there was a recent article trying to tell us that maybe we need better KPIs. We are not able to tell how the follicular development is going on, like recruitment, selection, growth, and dominance, you see. So now we are introducing new terminologies. Early FOD, that means all the follicles that on the 550, you had about 10 or 11 millimeters, and then to see how much from the AFC, how much came midway, how many came midway at least. And then the modified FOD, which is the similar one where at the time of your trigger, how many were measuring 12 and above? You see, 12, even 12 and above. Then the extension of the egg retrieval rate or the modified retrieval rate, number of eggs that we have retrieved in proportion to the total number of follicles within the maturation stage, 12, more than 12, and more than 16, to show that nearly all of the follicles that are responsive have been accounted for, you see. And then FOI, they have the advanced FOI, that means the total number of eggs retrieved at the time I've retrieved it in comparison to AFC. And then out of these eggs that are retrieved, how many are mature? This is sort of a fine tuning of how efficient we are in doing our stimulation. Individualized, but no point individualizing if we don't show a good sort of outcome as well. So once we validate and adopt this in clinical practice, we envisage that this new expanded KPIs can measure the effect of ovarian stimulation of follicular development in terms of the recruitment, how many we recruit, how many we can select, how many will grow, and how many will gain dominance, so that we can show outcomes in terms of live birth rates as well. So this is the study for those of you who are interested. Please take a picture of this. This is the study. This is a very nice algorithm. It will take me a long time to explain, but the principles are, as I mentioned earlier, this is, I think, what we are we are moving towards in ovarian stimulation. So very quickly, I want to thank you for your patience, and I'm sorry I went a bit longer. Thank you, and I'll take questions later.
Thank you, Dr. Suresh. That was a wonderful presentation. Thank you for sharing your expertise in ovarian stimulation with us. And for now, I think let's now continue with our next talk. We are honored to have Dr. Haryasa, obstetric and gynecology specialist, fetal maternal subspecialist, who will be speaking on luteal phase defect and fetal programming, association with fetal origin adult disease. Dr. Haryasa, please begin when you are ready.
Thank you, Dr. Alicia, as the moderator. I'm very honored to present in this great moment, yeah. And I also will say thank you to Professor Sri Maliawan as my guru and also as my role model. Thank you, Prof. Sri. And also I would like to say hello to Dr. Suresh and also my great friend, my best friend, Professor Kusumadana, as the director of Monash IVF Center in Bali. Yeah, and also Dr. Andreas. Say hello for your great presentation.
Thank you. Thank you. Thank you so much. I'm eager to listen to yours.
Okay, I would like to share my presentation. Okay, is my PowerPoint already
Very clear. But
very clear?
slideshow, please.
Wait a moment, Prof. Okay. 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 In this time, I would like to just reminding us about how the small early things can affect to the future in the fetal programming. This is my very interesting topic, and I also already presented this presentation in many scientific moments, because we are talking about how the civilization of the humanity in this world. Yeah, I'm Dr. Nyoman Haryasa Sanjaya. My background is the ONG doctor and also subspecialist in maternal fetal medicine. I believe all of us very understand about the cycle of menstruation. And more specific thing in my presentation is about the luteal phase. The luteal phase is very short moment of time during the menstrual cycle, but very important impact to the fetal programming. Many conference and also group, scientific and clinician group create the research and make the protocol in this issue, and how the luteal phase defect can create the big problem about the human growth and development. My concern in this presentation is how progesterone concentration can influence week by week of the pregnancy growth and development. How progesterone concentration from the corpus luteum production and will be continuous produced by placenta in the luteal placental sieve. This is the concern. Yes, as the obstetrician, also as the fertility consultant, and also maternal fetal medicine consultant, we must work together, yeah, to improve the deep research about the luteal placental shift, because this is the our area, our concern, how to give the future, the good future for the forward fetal programming. We can look in this data, luteal placental shift, like the process of the transfer from the corpus luteum production of progesterone to replace by placental production of the progesterone itself. Luteal phase defect is a condition where the body fails to produce sufficient progesterone during the luteal phase of the menstrual cycle. This condition will be impact to the process of the implantation, process of the growth and development of embryo, and will be create the problem of the placental forming from 2 until 3 weeks after conception. This is very short time, but the impact is very wide and very worse impact in the process of the anatomic forming, in the process of the growth and development, in the process of the many risks during pregnancy, like preeclampsia, like the other metabolic problem, also may be associated with the prolonged disease after baby born and in adult disease. We have the concern about the hypothesis, Barker hypothesis, and that published about the fetal origin adult disease. This image is just to try to make the understanding of the where part process of luteal phase defect will be create the concentration of progesterone production will be failed or will be insufficient in ovarian part, in endometrium, can affecting to two process of angiogenesis and also the process of fasciculogenesis. The fetal programming refer to the influence of intrauterine environment on fetal development. This process affect the fetus ability to adapt to its environment and increasing the risk of disease in adulthood. We can find the many conditions in maternal, such as like the diabetic in pregnancy, chronic hypertension, and also other metabolic disorder can create the placental pathologies and in utero programming. But the association, like the PCOS, like the artificial reproductive technology, unfortunately, also can create the problem in the placental pathologies, and then the outcome is impacting in developmental stage, like the macrosomia, atherosclerosis, and also many unknown diseases. Also in the childhood moment, like obesity, we can find many children suffering by the obesity, adiposity, and unfortunately many cases of the chronic disease like the cerebral vascular disease and also unknown disease. The impact of luteal phase defect on fetal programming that create the effect fetal programming in several ways, like the deficiency of progesterone. Progesterone is the crucial for fetal development. Deficiency can impact organ and system development. Epigenetic changes, luteal phase defect can lead to epigenetic changes. Epigenetic changes is the changes of the genetic that is not inherited by the old generation before, but actually because of the changes of the environment during pregnancy and influencing the gene expression and increasing disease risk. And oxidative stress also is as the impact of luteal phase defect can increasing oxidative distress affecting fetal development. It's very simple. Progesterone deficiency, progesterone insufficiency can create many prolonged impact for the human growth and development. Fetal programming can be affected by luteal phase of the menstrual cycle. When the luteal phase is impaired, it can lead to fetal growth restriction and fetal loss. How the luteal phase affect fetal development? That's impacting to the immune system. T regulator cell generation can disrupt by the impaired or luteal phase signaling. That is also will be answer for why normal pregnant woman in the with the luteal phase defect can create the hypertension in pregnancy, create the preeclampsia, and create also the failure of the creating adaptation of the vascular in placenta, and that's create the insufficiency of placenta in the beginning step of pregnancy. Preeclampsia is still the question mark, still the disease of theory. But I believe immune defect, immune deficiency, immune disruption correlated with the early beginning, the early small beginning process, such as the luteal phase defect. The placenta development impairment impairs luteal phase signaling can lead to abnormal placenta development. The placenta development can be performed not only in soup, but also can abnormal in fashion. And now we're talking about we suffering by the many increasing the placental abnormalities, such as the placental adhesive abnormalities, such as the placenta accreta. The decidual facial remodeling, the impairment luteal phase signaling can lead to defect of decidual facial remodeling. That is the base process of mechanism of the placenta problem, which I already spoke before. Okay, this is just the image how the connecting maternal and fetal, and we have the principle of the maternal fetal mirror phenomena. What this clinical performance in maternal will be also present in the fetal performance. And also we can look what happened in the fetus inside in the womb from the expression of mother. Yeah, such as like the fetal hydrops, and what the expression in maternal. Maternal also become like hydrops. the water retention. And in the beginning of the presentation, Dr. Andreas, how we make the diagnosis, not depend on the high-tech and costly diagnostic procedure. We must back to the basic, look to the physical examination, back to anamnesis, back to the data from the symptom and sign, and then assess something abnormal in the fetus, not only based on the high-tech procedure for the diagnosis, like the imaging, like the MRI, or other invasive diagnostic procedure. But we must go to basic procedure to make diagnosis of the baby, of the fetus growth and development based on the maternal performance. Fetal programming and fetal origin adult disease. This is the big issue. If we would like to talking about the how to prevent, how to stop the stunting, how to create the fetal of the human growth and development become much better in the future. We will start from the beginning, early beginning process from the luteal phase. The disruption fetal programming increasing the many problems in adult, such as like metabolic disorder, also degenerative disease, such as like what the Dr. Andreas video in the first session in the Canada. The first disease is the cancer. Cancer is the degenerative disease. I strongly believe the disruption of fetal programming can create the cancer in the future. Cardiovascular disease in the future because of the anomaly or pathologic, the small little thing in the beginning of the pregnancy process, in the beginning of the fetal programming. Also, many scientists and many clinicians already got the evidence how the small early process in the beginning of the pregnancy, such as like luteal phase defect, can stimulate to lead the neuropsychiatric disorder like depression, anxiety, and developmental disorder. And I strongly believe the presentation of the quality of politician in this world currently may be associated with the luteal phase insufficiency in their beginning of their pregnancy. And the last one is respiratory disease like asthma and chronic obstruction pulmonary disease. Is also as the disease during adult created by the abnormality in beginning of early small things in beginning of pregnancy. And how we can do the prevention and the treatment. We must start to do the many effort from the prenatal or pre-pregnancy screening to identify, to detect the early risk factors. We also can give the administration of the progesterone and hormonal replacement with the right and correct and also rational and humanistic, not induced by the commercial or health industry. We must be rational, must be humanistic, do the humanistic approach to create in the process of the beginning in pregnancy. And also we need improve the quality of pregnancy management. From the basic thing is like nutrition, exercise, stress management. And the last is the fetal monitoring. For us in the fetal medicine, we have the very exponential of growing technology, of the growing artificial intelligence, but we must going back to the basic of human being to understand of the bonding between mother, father, and unborn baby, also the society, to concern to put the mother and the fetus programming as our first concern to give the human being become kind and honor. This is my conclusion. Luteal phase defect can affect fetal programming. I will speak again. Luteal phase defect can affect luteal fetal programming, increasing adult disease risk. And my conclusion, prenatal screening, pregnancy management, and hormone therapy are crucial for preventing fetal programming disruption. Thank you very much for your attention, and I hope we can continue in the discussion.
Thank you, Dr. Haryasa, for that insightful talk for the importance of the luteal phase defect, the short early phase to many problems in adulthood, from metabolic problems until neuropsychiatric disorder. And now I think we'll now proceed to our last but not least speaker, Dr. Iwayan Kesumadana, obstetric and gynecology specialist, reproductive endocrinology and fertility consultant. For Dr. Kesumadana will present on infertility update risk factors, treatment and prevention. Please join me in welcoming Dr. Kesumadana. Dr. Kesumadana, the screen is yours.
Okay, thank you to the moderator. I think I at last, yeah, and I appreciate frankly with the two speakers earlier, yeah, Dr. Suresh and Dr. Haryasa. Good evening, or maybe good night now, for all audience, yeah. Who may respect to my teacher, Prof. Maliawan, and also Dr. Andreas, yeah, thank for sharing your knowledge, yeah, for ethical and legal aspect. And then I would like to talk about the presentation. Dr. Suresh, yeah, that is my teacher too. As long as we stand in the Bali Fertility Monash IVF, yeah, he give me many education and guidance. Thank you, Dr. Suresh. And
Most
also,
welcome, Dr. Kusumadana. We work together for the betterment of our patients.
yes,
You're a brilliant IVF doctor.
no,
Yeah.
you are the brilliant. Thank you.
you.
And I'm not professor. I'm sorry. That's just the joke from Dr. Suresh and Dr. Haryasa. I'm a doctor. Also, I want to the Dr. Haryasa, that the best friend, yeah. Yeah. Okay, for our presentation today, we choose, I will try to share my, yeah, okay, first thing, yeah. You can see all?
Yes.
Our slide? Yes, thank you.
Yes, very clear.
Yeah, thank you. And all our audience, I hope is stand on the stage too. Now we will to talk about the influence of the endometrial microbiota and pregnancy outcome in the ERT. We know that the success or successful embryo implantation in ART that determine and majority embryo quality as talk as the Dr. Suresh to make the quality embryo or embryo quality. And then the second, the endometrial receptivity. The endometrial receptivity based on the hormonal condition, estrogen and progesterone. Let's agree with Dr. Haryasa for progesterone luteal phase can in fact for the implantation, for growing of the baby or the pregnancy continuing. And the second, anatomy, hyperplasia, polyp, and myome. And then now we will talk about the immunity system as the microbiota and endometrium and vagina. Even is still in debate of the effect or the influence of the microbiota in the successful of the ART. Endometrial receptivity play a crucial role in IVF success. The recent study suggests microbiota influence endometrial function, and then endometrial microbiota composition affect implantation and successful of the pregnancy. And if the unbalance or dysbiosis of the microbiota, especially in the vagina and in the endometrium, that link to the IVF failure. Now we will to talk about how to immune modulatory role in endometrial microbiome in implantation. Microbiome play a crucial role in the functional of the immune system and creating a favorable improvement necessary for the successful of implantation. The involvement of cytokine in endometrial receptivity and embryo development give rise to multifaceted improvement, which is further impacted by such as the diet, stress, injury, infection, and inflammation. And also that the influence of balancing pro-inflammatory and anti-inflammatory response in the endometrium. A receptive endometrium require to find a immune milieu to allow embryo implantation without eliciting the destructive inflammatory response. That is a picture or the fig for the implantation process. I think that all of to know that how to implant it, the blastocase in the endometrium, that a few steps, yeah. First, maybe we call the opposition, and the second addition, and then continue with the infusion, where the blastocase implanted until the mucosa or until in the stroma of the endometrium, and then with the continuing full implantation. That the cascade or maybe the step that the effect from the maternal immune tolerance. Yeah, how to maternal immune tolerance that can the shape of the immunity system and the cytokine involved in that the tolerance that making the success of embryo implantation. Also immune and hormone in microbiota to talk about there that we show the compare and the fertility and infertility patient. Yeah, in the fertility patient, we show that have the regulated T cell, appropriate activity uterine NK cell, and M2 or anti-inflammatory macrophage and teratogenic dendritic cell in the fertility woman or patient, and give the shape over to the implantation failure if the regulatory cell change to the effector cell, and then the uterine NK cell under activity or overactivity, and the action of macrophage pro-inflammatory can make the failure to implantation. This is the microbiota in endometrium. What is that, the composition? The Lactobacillus dominant, or LD, with the Lactobacillus species, abundant percentage greater than 90%, and then in non-Lactobacillus dominant or non-LD with Lactobacillus species, abundance percentage and smaller than 90%, and other species prominent in sample include Bifidobacterium. Women with LD type microbiome had highest chance of the successful implantation, full-term pregnancy, and live birth. And the contrast, abundance of the other genera and the decreased presence of the Lactobacillus in their microbiome were significantly less likely to achieve pregnancy and more likely to suffering of the miscarriage. And non-LD type microbiome is also associated with the pathologic condition and disease of the endometrium, such as the endometriosis and chronic endometriosis. That is the composition of the microbiota. It will change the composition that can make the failure to implantation or maybe the pregnancy loss. Endometrium microbiota composition and reproductive outcome, that as the above, the theoretical of non-sterile uterus along with accumulating evidence highlighting the importance of the uterine microbiota in female health indicate that the bacterial community are crucial for maintaining the pregnancy. With the diagnosis we call the next generation sequencing, NGS, has made it easier to use the technique like 16S RNA gain sequencing, which has used to many studies that describe to different type or different genus of the microbes that live in the uterine cavity. Even a few studies use of the other gain sequencing, but the most study using the 16 years RNA gain sequencing for describe the different type of the microbiome. In IVF procedure might not work as well if this bacteria community change because they trigger immune response and change the metabolism. In addition, there exists the divergence of the opinion concerning the impact of the endometrium microbiome and reproductive outcome. That is why until now, and no consensus or no guide for what the composition, what the beneficial bacterial or maybe agent in the uterine and the vagina, but need to further research for to make diagnosis evident. This is the study or research in microbiota in ERT. In 2022, the Immaculata Moreno and et al. That the topic of the endometrium microbiota composition is associated with the reproductive outcome in infertile patients. That the background because they aim to determine whether the endometrium microbiota composition in associated with reproductive outcome of live birth, biochemical pregnancy, clinical miscarriage, or maybe no pregnancy. That the method using the multi-center prospective observational study using 16S RNA gain sequencing to analyze endometrial fluid and biopsy sample before embryo transfer in cohort of the 342 infertile patients asymptomatic for infection undergoing assisted reproductive treatment. What the result of this research? The dysbiotic or imbalance of the endometrium microbiota profile composed is Atopobium bifidobacterium, Rhizobacterium, Gardnerella, Haemophilus, Klebsiella, Neisseria, and so on, and include in the dysbiosis of endometrium biota. What the conclusion of this research? That the finding indicate that endometrial microbiota composition before embryo transfer is crucial biomarker to predict reproductive outcome, offering an opportunity to further improve diagnosis and treatment strategies. The other side, the journal Reproductive Immunology that discuss about the role of the endometrial microbiome in embryo implantation and recurrent implantation failure. That the highlight of the topic, there is a suspected association between the endometrial microbiota and the pathogenesis of implantation failure. The impact of the bacterial community in the endometrium on human reproductive is still subject of debate. Yeah. This knowledge is crucial for comprehending the factors that influence fertility and the maintenance of the successful pregnancy. The other side, the Journal of Reproductive Immunology in the same time, 2024, that the new journal has discussed about the microbiome and recurrent pregnancy loss. It's coughing few. That the highlight, but the matter more is this biosis impact of the recurrent pregnancy loss alter the microbiome balance linked to the recurrent pregnancy loss. Immune microbiome interaction in RPL or in recurrent pregnancy loss, host microbe crosstalk shape pregnancy outcome. The microbiome profiling for personalized RPL diagnosis, that the novel potential marker for individual susceptibility. The therapeutic prospect targeting the microbiome for improve the pregnancy success in recurrent pregnancy loss. What the clinical approach to the endometrial microbiome related to the recurrent implantation failure? Women with the recurrent implantation failure separated into the group with eubiosis. Eubiosis is balance of the microbiome, and the dysbiosis or unbalanced microbiome had their endometrial microbiome and the few specific implantatory marker examined. In comparison, the woman with eubiosis, the dysbiosis group show significantly higher level of inflammatory marker as the interleukin 6, interleukin 1, HIP1, and COX2, and significant lower level of the anti-inflammatory factor as the interleukin 10 and IGF-1. Patients with non-lactobacillus instead of the RAF underwent evaluation of various therapeutic modality. Patients with the NLD were treated with the either oral probiotic, antibiotic, or oral probiotic and vagina antibiotic. Cure rate were established by the re-evaluating the endometrial microbiome after treatment. That the found Gardnerella vaginalis was the most often found bacterium and made up 44 and 9.9% of the endometrial microbiota and recurrent implantation failure patient. The cure rate varied between the 29%, 30%, and the higher is the 78% in the group of the treatment with the prebiotic and antibiotic. Microbiome might be effect of endometrial receptivity. Until now, that the no consensus of the axis of the cure uterine microbiome. Evidence show that dominant of lactobacillus species, we call the eubiosis condition, improve chance of the successful implantation and ongoing pregnancy. Vagina and endometrial dysbiosis can cause local inflammation and increase of pro-inflammatory cytokine, compromising the integrity and receptivity of the endometrial mucosa that hampering the successful embryo implantation. It seems that recurrent implantation as well as recurrent pregnancy loss are both associated with the increase in the microbiome diversity and loss of Lactobacillus dominans in the lower female reproductive system. Yeah, that the figure or that the picture about eubiotic vagina and endometrial microbiota and the alter of the vaginal endometrial microbiota. Then we can show that in the eubiosis that the majority of the lactobacillus component compared than the other genera of the bacteria. Yeah. That the contrast in the alter of the vaginal endometrial microbiota in the recurrent implantation failure can improve the pro-inflammatory, can increase the pro-inflammatory cytokine, inflammation and activation of the local immune system that affect the integrity of endometrial mucosa and impair the embryo implantation. That the research or the study can inform us about the controlling ovarian stimulation and progesterone supplementation affect vaginal and endometrial microbiota in IVF cycle. That the pilot study in 2020 with the Andreas Caruso. That the purpose of this study, using the controlling ovarian stimulation and progesterone in luteal supplementation modify the vaginal and endometrial microbiota, a woman undergoing in vitro fertilization. The method of this study, 15 women underwent microbiota analysis in 2 time points during the mock transfer performed and in the luteal phase of the cycling preceding the choice and at the time of fresh embryo transfer. Vagina swab and distal extremity of the embryo catheter tip were analyzed using next generation 16 siRNA gene sequencing. Heterogeneity of the bacterial microbiota was assessed according to the board of using the data. Then the conclusion finding in the study suggests that the controlling ovarian stimulation and progesterone supplementation significantly change the composition of vagina and endometrial microbiota. The greater instability could affect both endometrial receptivity and placenta state. If our findings are confirmed, they might provide a further reason to encourage the freeze-all strategy. The freeze-all strategy can create of the minimize the chain of the microbiota composition during the control ovarian stimulation and progesterone supplementation.
Apologize for the interruption, Dr.
Okay,
Kesupudana.
that the one of the study can inform us about the endometrial vaginal microbiome influence the assisted reproductive technology. That the result of this can conclude the balance between lactobacillus and pathologic bacteria abundant in the endometrial and vaginal microbiome associated with the pregnancy from ERT. That the group of the composition bacterial in the endometrial showing the data if the high level of lactobacillus and low level of pathogen bacteria, the pregnant was increased compared than the non-pregnant woman and in the vagina too. This is the data with the can inform us the vaginal endometrial microbiota dysbiosis associated with adverse infant transfer outcome. That the purpose of this study to investigate reproductive tract dysbiosis, identify different bacteria and reproductive tract as potential biomarker of embryo implantation failure and demonstrate the pathogenesis through the metabolysis analysis. That the conclusion of this study to clarify sexual independent relationship of bacterial in vagina and endometrial fluid on embryo implantation failure and undoubtedly broaden to understanding about female reproductive health.
Dr. Kesupudana.
Yes.
I'm sorry to
The
interrupt.
take-home for this
Yes.
sentence, the microbiota play crucial role in endometrium receptivity and IVF outcome. Understanding this relationship can improve the IVF success. Thank you, Matur Susuma, and terima kasih. It will offer to the moderator again. Thank you.
Thank you, Dr. Kusumadana, for that comprehensive presentation about the endometrial microbiome. And now I think we will open the floor for questions. Please raise your hand or use the chat feature to ask your questions. Kindly state your name and affiliation before your question. Okay, since I didn't see any questions, so I think I will ask some questions to the speakers. First, I would like to ask to Dr. Kusumadana and Dr. Suresh. Since most of the participants are the general OBGYN, I want to ask if we want to do ovulation induction just with clomiphene citrate or letrozole. For Dr. Suresh, is it better to use AMH rather than IFC to begin the ovulation induction? And after that, how can we improve the endometrial microbiota for the Dr. Kusumadana if we want to use the vaginal probiotics? How many is the dose of the vaginal probiotics? And I would like also to ask to Dr. Haryasa to continue the questions. For the importance of the luteal phase defect, if we don't do the IVF, just do the ovulation induction, do we have to give the progesterone also to the patient? If yes, when and which progesterone can we use? Thank you, doctor.
I think Dr. Suresh can answer this, the first question, maybe.
Okay.
Yeah.
So, Alyssa, sorry, can you repeat the question again for me?
Oh, okay. If we want to do the ovulation induction just with the
Yes.
chlorine hydrate or the letrozole, can we also use AMH to begin the ovulation induction, or we can do the ultrasound to use the AFC, doctor?
That's a good question, because if you're using letrozole, generally the tendency is for us to do it in a low-cost method, and you have to do an ultrasound scan in any case, you see. Now,
Yes.
I do, as a mandatory step, beta HCG whenever I use letrozole, although there is some data to suggest that the cardiac defects are not common. There were two large Canadian studies that shows there was a higher incidence of cardiac defects. So in a very medical legal climate as ours is now, I tend to do the HCG. And because I do HCG, I also will check on the estrogen levels as well as the AMH, you see. So that's part of my routine. I'm not saying that you ought to do it. It is good practice to do it if it is less costly. Why is AMH going to be important? Because if you find that you have plenty of antral follicles, but strangely very low AMH, then you might be dealing with someone with might be resistant to letrozole. Also remember that to use letrozole, you need an intact pituitary ovarian axis. So some of us have been on contraceptive pills for a longest time, or you have been on Leucrin in a preceding cycle, and you want to do a stimulated, maybe the last cycle with a hormone replacement, you could not, the pregnancy was not achieved, and therefore you have a significantly lowered LH. A pituitary gland has to be functioning to use letrozole. Now, how letrozole works is it blocks the estrogen receptors and gives it the feedback that there aren't any estrogen circulating, and therefore your FSH and LH is coming out, you see?
Yes.
So in that regard, useful, but not mandatory. So if you're going to do the low-cost method, go ahead and start with letrozole. At least tell the patient, do a urinary pregnancy test when she wakes up, because the last thing we want is she's inadvertently pregnant. And I tell you this because, again, I'm involved in many medical legal cases as an expert witness. expert giving expert comments. And there have been instances where this has happened. And although they claim that there aren't chances of birth defect in some of the studies, there is a significant amount of data to suggest that there might be birth defects as well. It is not as innocuous as clomiphene, you see. So that being the case, I'm doing defensive medicine. I'm not saying this is standard of care, but it is defensive medicine. The other question you asked is, can you use AFC? Absolutely, you should use AFC. It gives you a number of follicles, because even letrozole can give you more than one follicle, although it is a better agent to use because it's generally monofollicular. Compared to clomiphene, this is more likely to be monofollicular. If in case you want to grow this follicle and then add gonadotrophins, I would suggest that you see the patient within day 3 to day 7 or day 2 to day 6 is your letrozole, 2.5 maybe. Then you see the patient round about maybe 9th or 10th day. And if you see, sometimes the follicles are very large. So it's a very fast, rapid growth. And it is likely that you had premature sort of recruitment of the follicle in day 2 or day 3 of your cycle. Usually we see it in the range of a pre-ovulatory phase, maybe between 12 to 16. And sometimes you might want to use a bit of maybe Gonal-F, Pergoveris, Menopur, Purogon, just to nudge it, and also use antagonists so that if you're going to use a IUI, this to do IUI, you can time it very accurately. One of the main reasons why IUI does not work as well is timing of ovulation. We can't use just urinary LH. It's too sort of wide range, you see?
Yes. Okay. Thank you so much, Dr. Suresh.
Mhm.
And for the Dr. Kusumadana, do you have any opinion about that?
Okay. Thank you. The good question about the microbiota. We know that the microorganism or microbiota not only in the reproductive tract that can spreading into our body, especially in the gut microbiome too. But for the kill of the pathologic bacteria in the composition of the microorganism, based on when we the majority kill for that, if only the in reproductive tract killing the microbiota can use the vagina probiotic that more safer and more localized compared than the oral. But the other side, the oral macrobiotic as the composition of the probiotic and prebiotic that safer and making good kill for the bad bacteria, even in the endometrium, even in the gut microbiome too, can kill the all of the microorganism. But that's why based on the what the toward to the kill of the microbiota, if we want to kill the microbiota in the endometrium and vagina, I think using the oral pro and prebiotic can improve the condition compared than only vaginal probiotic. I think that's our answer.
Thank you, Dr. Kusumadana, for the answer. And for Dr. Haryasa, can we hear the answer for the question?
Okay, thank you, Dr. Alicia, for your question. And I believe that is very common issue, yeah, and question in our practicing in
Yes.
diet practice, yeah. And your question is when and how much progesterone is given in non-IVF pregnancy, yeah. Indication for progesterone administration, we can look in the history, like the history of miscarriage or the luteal phase defect, yeah, and the threatened miscarriage. We can start from to give the progesterone in the dose of progesterone administered from the common doses range from 200 until 400 milligram per day, often given in the form of vaginal suppository or capsule. The timing progesterone is typically start from after ovulation. Yeah, around days 14 to day 16 of menstrual cycle, and continue until the first trimester of pregnancy, usually until up to 12 weeks of gestation. I think that is my answer. Thank you for your question, Dr. Alicia.
Thank you, Dr. Haryasa, for the answer. Okay, so because we are running out of time, I will have to conclude this webinar. As we conclude today's webinar, I would like to extend our deepest appreciation to all our speakers, panelists, and participants. Your engagement and enthusiasm have made this event a great success. We hope today's discussion have provided valuable insights that you can apply in your practice. Thank you once again to our organizers and sponsors for making this event possible. Look forward to seeing you at future events. Have a great night.
Thank you to the president
Thank you very much.
and all my co-speakers, and also our moderator, Dr. Anil. Thank you very much.
Thank you very
Have
much.
a lovely weekend, everyone.
Can I
you.
talk a little bit? Okay.
Yeah.
Please,
Thank
please,
you.
Dr.
Okay. Yeah, okay. As it's my great pleasure to have you four distinguished speaker in this serial webinar of ICS Indonesian section. We have Dr. Andreas, Dr. Suresh Nair, hello, Dr. Haryasa Sanjaya, and Dr. Kusumadana. You share your expertise very clear and in a great presentation. Thank you for all participants and very attractive, very good moderator, and all who participate in this webinar. Thank you for all distinguished speakers and moderator. Thank you for the participant also. Thank you. Welcome to the next webinar, serial webinar for ICS Indonesian section. Thank you. Good night.
Thank you, President. Thank you.
Thank you,
Good
Professor.
night, everyone.
Thank
Good night,
Bye.
everyone. Bye-bye.
Bye.
And all, see you next.
Oh, orang ini mak barang kok bisa habis.